Dizziness and balance disorders act as exact indicators of neurological failure deep within the vestibular system. This internal disconnect cascades outward, projecting as blurred visual fields and the sudden loss of gait stability. These overlapping neural pathways also dictate cranial facial control. A breakdown here manifests as facial asymmetry and mechanical restriction in the jaw. This conceptual model isolates the anatomy targeted by ENT physiotherapy, the clinical discipline designed to reconstruct these degraded connections. The process enforces synchronization between the inner ear, the central nervous system, local cervical musculature, and airway mechanics. The objective is the reconstruction of core physical stability, fine motor coordination, and complete functional recovery. Suppressing a single symptom, like vertigo, ignores the underlying sensory mismatch, leaving the entire neuromechanical architecture prone to recurrence. This cross-section of the inner ear highlights where the recalibration begins. Pathologies like benign paroxysmal positional vertigo, vestibular neuritis, and Meniere's disease stem from microscopic structural failures. Displaced calcium crystals or altered fluid dynamics send erratic, inaccurate spatial data directly into the brain. We intercept this faulty data through eye movement exercises and advanced vestibular tracking protocols. For displaced crystals, physical interventions like the Epley maneuver utilize gravity and specific head positioning to mechanically relocate the otoconia back into their correct position. This physical correction forces the central nervous system to adapt, processing spatial sensory inputs accurately once again. Once the inner ear is synchronized, targeted gait rehabilitation reconstructs dynamic walking stability. Advanced balance retraining then challenges these newly aligned systems to secure long-term spatial awareness. Correcting vestibular dysfunction demands a dual approach, physically repairing the inner ear mechanics while training the brain to process the new sensory data. This map of the facial nerve architecture illustrates the degraded signaling along cranial nerve 7, visible in conditions such as Bell's palsy and post-surgical facial weakness. This lack of neural drive yields biomechanical failures, presenting as reduced blinking capacity and asymmetrical motor control. Re-establishing command over these paralyzed zones requires dedicated facial neuromuscular retraining. We utilize specific mirror biofeedback protocols to actively bridge the clinical gap between neurological intent and physical execution. Concurrently, targeted soft tissue mobilization maintains muscular pliability, preventing contracture in the inactive zones. Precise relaxation therapy is layered into the protocol to inhibit uncoordinated muscle spasms during the reinnervation phase. Restoring facial function is an active reconstruction of the brain's autonomic motor control maps. Tracking down the kinetic chain, this biomechanical overlay of the temporomandibular joint and cervical spine reveals how structural misalignment degrades cranial facial function. Misalignment here dictates specific clinical symptoms: audible jaw clicking, intense referred headaches, and chronic cervical stiffness. Because the temporomandibular joint sits millimeters from the auditory canal, local inflammation frequently translates into ear-related jaw pain. The clinical response relies on posture correction combined with precise jaw mobility drills to restore normal articular glide. Deep cervical stabilization techniques eliminate the muscular overcompensation that drags the jaw off its correct axis. This cervical stability directly impacts the vestibular system, as a misaligned neck prevents accurate head positioning data from reaching the inner ear. Isolated TMJ treatment is insufficient without first stabilizing the cervical biomechanics that act as the foundation for the cranium. Beneath local joint mechanics lies the baseline of physical stability, the airway and breathing mechanics. Airway dysfunction presents as chronic mouth breathing, rapid voice fatigue, and postural breathing disorders. This cross-section of the thoracic cavity contrasts the inefficiency of rapid apical chest breathing against 360-degree diaphragmatic expansion. Correcting this requires dedicated diaphragm training and thoracic mobility work to unlock the ribcage. These principles govern recovery during post-surgical ENT rehabilitation, following complex sinus, thyroid, ear, or neck procedures. The immediate post-operative priority is the targeted reduction of rigid scar tissue stiffness to prevent long-term mobility loss. Restoring airway mechanics and tissue pliability directly accelerates the stabilization of post-operative balance. Efficient breathing and unhindered tissue mobility are the required physiological baselines for high-demand physical performance. From the inner ear to the diaphragm, functional recovery demands an integrated approach to these overlapping systems. This is the standard at Karlos Sports Science, an advanced facility defined by vestibular protocols and evidence-based rehabilitation. We rely on objective measurement, utilizing comprehensive movement analysis and neuromuscular assessments to track exact physiological metrics. Karlos Sports Science utilizes a structured recovery system designed to restore function with a speed and safety that symptom management alone cannot provide. We implement biomechanical correction strategies built specifically for performance-focused recovery. True recovery encompasses the restoration of movement quality, balance, breathing efficiency, and high-level functional performance. We actively engineer a resilient, highly calibrated performance system, moving beyond the passive timeline of tissue healing. Karlos Sports Science, evidence-based ENT physiotherapy and functional rehabilitation. Restore balance, rebuild function.